Very much. I appreciate it, and I apologize for being late. We have activities, and I'm going to have to excuse myself before we're all through. This is also Senator Cowan's last day, and he'll be making his remarks from the floor, so I will be joining him. But I do want to thank you, and I want to thank Ranking Member Collins for scheduling this hearing and for reopening the conversation about advanced planning for medical treatment. Too often in today's healthcare system, medical care is focused on treating a disease, not on helping an individual patient. It used to be that a family or town doctor would treat a person for most of their lives for any medical issue. People and their doctors built up strong bonds over time, and physicians knew their patients as unique individuals. Advancement in science and medicine gradually caused more and more doctors to begin specializing and only treating certain diseases or certain parts of the body. And now, according to the CDC, only 56% of office visits are to a primary care doctor. Patients, especially seniors, see several specialty doctors each year that focus on different aspects of the individual's clinical needs. So we're slowly gaining evidence that coordination among doctors, giving specialized care, can improve a patient's quality of life and keep people healthy longer. I'm proud that Medicare demonstrations like the Care Management Program at Massachusetts General Hospital are contributing to this evidence and improving our outcomes for seniors. Through the Affordable Care Act, we are encouraging even more coordinated care through medical homes and accountable care organizations. But in all of the talk about improving coordination and quality in health care, I think we've missed something vitally important, something we used to know way back when we had only one town doctor. Patients need to be treated like whole people, people with loved ones and families, people with dignity and values, not like a collection of parts and problems. Somehow we need to make sure that people are still being heard in medicine. So I'm looking forward to the testimony of our witnesses today, hearing about the tools that we have available to help patients participate in medical decision making along with their physicians and their loved ones, and about what stands in our way so we can begin to work through the barriers and ensure that our seniors' voices are being heard. I want to thank you all, and again, thank you, Mr. Chairman. Ms. Warshaw, I appreciate your question, and you asked, have we had the conversation? We should lead by example. I just want to take this chance to say publicly, yes, I've had the conversation. I had it twice. My Aunt Bee started in about 40 years before she died. She died at 98, having the conversation. She was a shy, self-effacing woman, but she was determined that I would know what she wanted when the time came. And when we lost my mother very suddenly, my father, after that, insisted on having the conversation. Both of them said, Betsy, we'll be depending on you. And I just want to say about the conversation, I had the confidence that I was doing what Aunt Bee wanted, what my daddy wanted. It was their final gift to me. And that's what really mattered about the conversation.
I've had it with my two adult children, young adult, but adult children, and it was a hard conversation to have because nobody wants to have this. No one wants to think of their parents' mortality, but to me, it's a gift to them. It's unburdening, making such difficult decisions. I never want them to have any regrets, and I had wonderful role models with my parents. Both of them have passed away, but I knew exactly what they wanted, and the last period of their end of their life was a joy to be with both of them.
Yes. So thank you. Thank you, and I encourage everyone to have the conversation. But what this conversation, what this discussion shows, are the many benefits that we have from treating the whole patient and the quality of life, both for the patient and for the loved ones, and how we should strengthen our ways for getting more information here. And we've heard some great tools today. But the question I want to ask is how we could improve our Medicare program to make certain that seniors are being treated with dignity and respect, receiving the quality health care that's consistent with their individual values. You know, there's a lot of power in Medicare, and I just want to start there if we can. Dr. Ramsey, could you comment on that, please?
Great, thank you. Again, in terms of my personal opinion, in terms of what the federal government has done, looking at back in 1992 with the PSDA, in terms of what were some of the opportunities that this particular legislation has provided. We've heard today that there is, Senator Warner is working on proposed legislation. And so I think that each of these that will have a teeth, if you will, that actually expresses some guidance would be enormously helpful for us. I think there was a lot of good that have come out of the PSDA. Was it, did we complete our total objectives? Not so much, but certainly we're long on our way. So I think that in terms of using prior laws, examples such as that particular federal law will help us as you look forward with the current legislation.
Good. Thank you. Mr. Towey, would you like to add anything on that?
Yes, Senator. It's a reimbursement system, so you've got to incent good practices. And so there should be a review of how hospitals and care facilities and care providers are doing with urging individuals to do advanced care planning and have discussions. Certainly funding hospice in ways that gets them an earlier encounter, an earlier discussion with patients. They often are only brought in at the very end. There's a bias, it's been documented by the Dartmouth research, that there's a bias toward hospitalization and curative care to the point where individuals, had they known what they were going to face the next 90 days, would not have tried radiation a third time. But often this isn't communicated. It's simply a physician saying, we're going to try this. So these conversations are best, I think, also incented in medical schools, where you start training the next generation of care providers to understand that if you're really going to be in the caring professions, you can't simply treat them as an object for your health care practice, that you have to help them understand here's what's ahead if you choose this option versus this option. Often the patient has no access to a physician. And so then the discussion is held by a social worker who has no idea who the individual is, and it's broken down from the very beginning because their caseloads are too great and they're not funded anymore by Medicare. So I think that a good way for Medicare to leverage its money is to incent good practices, and also for us to be doing more with the medical schools to inform them about good pain management and earlier referral to hospice and better information for families and patients.
Good. Well, I see my time is up, but I just want to say thank you all. Thank you for the work you do every day. And thank you again, Mr. Chairman, for reopening this conversation for all of us.
Thank you.